Good afternoon. I'm about to start. All right. Yeah. The others can come in a little later. All right. So our topic today is tumor markers, so cancer markers, and quite interesting. The whole lot of them which are in the market today. And my first question that I'm asking you is, what are tumor markers, like we do in most PPTs? So tumor markers are molecules occurring in the blood or tissues that are associated with cancer and whose measurement or identification is useful in patients' diagnosis or clinical management. The ideal marker would be a blood test for cancer, in which a positive result may occur only in patients that have malignancy, that's cancer, one that can correlate with stage and response to treatment, and that has been easily and reproducibly measured. No tumor marker, no available, has met this ideal. So it's not ideal, it's only that when you have something that's positive, the doctor will investigate further. The purpose of screening: tumor markers may be useful. One of the four purposes: screening a healthy population or a high risk population for presence of cancer, making a diagnosis of cancer or of a specific type of cancer, determining the prognosis in a patient, monitoring the cause in a patient in remission or while receiving surgery, radiations, or chemotherapy. So there are populations that may be high risk, certain people, and that has to be investigated. The drawback: see, like I told you, no test meets all these requirements. Specifically, no marker has been established as practical cancer screening tool, either in a general healthy population or in most high-risk populations. The reason for this is a relatively lack of sensitivity and specificity of the available tests, given the low prevalence of cancers in most population groups. Given the low prevalence of cancer in general, even tests that are highly sensitive and specific may have low reproductive or predictive values. So keep that in mind. I told you, it's just a marker, it is just a guideline for the doctor to follow up. There are PET scans, and then there are tissue biopsies. That will be the final diagnosis. So what are risk markers? Some people have a greater chance of developing certain types of cancer because of a change known as a mutation or alteration in specific genes. The presence of such a change is sometimes called a risk marker, and there are quite a few now. Tests for risk markers can help the doctor to estimate a person's chance of developing a certain cancer. Risk markers can indicate that cancer is more likely to occur, where tumor markers can indicate the presence of cancer. Now see, these risk markers, there are risk markers especially for CA breast, for the ovaries and all that. And I think there was a very, very popular actress who had cancer in the family, and she tested positive for those risk markers. So what she did was, she went ahead and had a mastectomy done. She already had her children, and she already had a hysterectomy done. So her danger risk was more or less zero of developing breast cancer or ovarian cancer. Very, very popular actress. I will not mention the name. I'm sure you all know about it. Okay. So how are they used? Tumor markers are used in detection, diagnosis, and management of some types of cancers. Although an abnormal tumor marker level may suggest cancer, this alone is usually not enough to diagnose cancer. Therefore, measurement of tumor markers are usually combined with other tests such as biopsy to diagnose. I told you, where biopsy is very, very important, especially, fine needle when something is suggested. The needle is inserted, tissue sections are taken out, stained, and then the final diagnosis is made. All right. Significance. Tumor marker levels are also can be used to check how a patient is responding to treatment. So once we've established that yes, it is there, treatment starts, chemo, radio, etc., the doctor may use it to monitor if the person is responding well. A decrease or return to a normal level may indicate that the cancer is responding to therapy, whereas an increase may indicate the cancer is not responding and spreading. After treatment has ended, tumor markers levels may be used to check for recurrences. Bas bacha, enough cancer that has returned. Tumor marker levels may be measured after treatment to help doctor plan appropriate therapy. In some types of cancers, tumor marker levels reflect the stage, extent to which the disease has spread. And you remember, you've heard of third stage, fourth stage cancers, etc., especially with certain tumors, even in leukemias, it's a bad prognosis. How and when are tumor markers measured? The doctor takes a blood, urine, or tissue sample and sends it to the laboratory, where various methods are used to measure the level of the tumor marker. If a tumor marker is being used to determine whether a treatment is working or if there is recurrence, the tumor marker levels are often measured over a period of time to see if the levels are increasing or decreasing. Is obvious, isn't it? Usually, these serial measurements are more meaningful than a single measurement. Tumor marker levels may be checked at a time of diagnosis, before and during and after therapy, and then periodically to monitor the reoccurrence. So this is not a one-time thing. Once you establish that something may be there, the doctor will be monitoring the patient at regular intervals. And that's important. Can tumor markers be used as a screening test for cancer? That's the question we ask. Screening tests are a way of detecting cancer early, before there are any symptoms. For screening tests to be helpful, it should have high sensitivity and specificity. Sensitivity refers to test ability to identify people who have the disease. Remember, sensitivity. Specificity refers to the test's ability to identify people who do not have the disease. And in immunology, we use the term sensitivity and specificity very often. Most tumor markers are not sensitive or specific enough to be used for cancer screening. Example, PSA is used to screen men for prostate cancer and CA-125 for ovarian cancer in women. So these two are very, very common tests, men and women. Research in the field all the time, it never stops. NCI Early Detection Research Network is developing a number of genomic and proteomic based biomarkers, some of which are being validated. So you have to validate, right? You just can't say, oh, this is a new test in the market, and if it's positive, you have it. Cancer researchers are turning to proteomics, the study of protein, shape, function, and patterns of expression. This is something new that is very much in the market now, in hopes of developing better cancer screening and treatment options. Proteomic technology is being used to search for proteins that may serve as markers of disease in its early stages, or to predict the effectiveness of treatment or the chance of disease returning after treatment has ended. So it's quite specific. Scientists are also evaluating patterns of gene expression, the step required to translate what is in the gene to proteins, for the ability to predict a patient's prognosis, likely outcome of the course of disease, or response to therapy. So you know the meaning of prognosis and diagnosis, okay? Now these are the machines from Roche, and the methods used are immunohistochemistry, ELISA, ECLIA. Any one can be used. Immunohistochemistry is another ball game, okay? Few common types, I'm sure you've heard of it. Alpha fetoprotein, germ cell tumor, hepatocellular carcinoma, this used for this. CA15.3 breast marker, CA19.9 mainly pancreatic cancer, but also colorectal cancer and other types of gastrointestinal cancers. Carcinoembryonic antigen, CEA as we call it, gastrointestinal cancer, cervical cancer, lung cancer, ovarian cancer, breast cancer, urinary tract. Then you've got human chorionic gonadotropin, HCG, gestational trophoblastic disease, germ cell tumor and carcinoma, inhibin sex gonadal stromal tumor, adrenocortical carcinoma, hemangiomas. Okay, so some names may be a little new to you. Types continued. Prostate specific antigen, prostate cancers, I'm sure it's becoming very common in men. S100 protein melanoma, sarcoma, neurosarcoma, lipoma, chondrosarcoma, astrocytoma, gastrointestinal stroma tumors, salivary gland cancer, some types of adenocarcinoma, histiocytic tumor, dendritic cell macrophages. CA19.9 colon cancer, CA72 a glycoprotein in breast and colon cancer. See quite a bit of overlap as you can see. HE4 ovarian and CA125, CIFRA bladder cancers. I think maybe some of these names are new to you, but they have got to be quite common now. In this picture, of course, organ and type. With the organ, what can be related? You can take a look at it. All right. Stare at it for some time. You have it in your PPT. So that. No, that's okay. Then you come to alpha fetoprotein, AFP, getting to be very common and is very common. Alpha fetoprotein is a protein normally produced by the liver and yolk sac of the fetus. Alpha fetoprotein levels decrease soon after birth. AFP probably has no normal function in adults. Greater than normal levels of AFP may be used to detect cancer in testes, ovaries, biliary secretions, so biliary tract, stomach and pancreas. Also help to detect cirrhosis of the liver cancer, malignant teratoma, recovery from hepatitis. Alpha feto. Now we are picking up one by one which are quite popular. CA15.3 is a protein that is normally a product of breast tissue and does not cause breast cancer, but it does not cause, remember that. If a cancerous tumor cell growing out of control is present in the breast, though levels of CA15.3 may increase as the number of cancer cells increase, tumor cells will shed copies of CA15.3 protein, which may be measured by the blood test and by a related test of cancer. Cancer antigen 15.3, CA15.3, is a blood test that is given during and after treatment of breast cancers. It is most useful in monitoring advanced breast cancer and response to treatment. Cancer CA15.3 is not a blood test that screens for breast cancer, keep that in mind. It is a tumor marker test which is helping in tracking the cancers that produce CA15.3. And you've got the pink ribbon, which is a sign of breast cancer, as you know. CA19.9 is a tumor marker of substance produced because of cancer. This was first developed for colon cancer. However, it has been found to be very sensitive indicator of pancreatic cancer also. See, so there are overlaps. CA19.9 is used to evaluate how a patient is responding to cancer treatment or to differentiate between types of cancers like bile duct cancer or pancreatic cancer. It also indicates recurrence of pancreatic cancer. Can't be used as a screening test. So there are certain inhibitions. And you can see the person undergoing a scan and the cytology involved. CEA, the carcinoembryonic cancer antigen test, measures the amount of this protein that may appear in the blood of some people who have certain types of cancers, especially large intestine, colon, or rectal cancer. It may also be present in people with cancer of the pancreas, breast, ovary, and lung. So see, there are quite a few overlaps. CA is normally produced during the development of fetus. The production of CA stops before birth, and it usually is not present in the blood of healthy people. Carcinoembryonic antigen CEA test is used to find how widespread the cancer is in some types of diseases, especially colon cancer. Check the success rate of the treatment for colon cancer. CA levels may be measured both before and after surgery to evaluate both the success of the surgery and the person's chances of recovery. CA levels may be measured during treatment with medicines to destroy cancer cells, chemotherapy. This provides information of how well the treatment is working. Check to see if the cancer has returned after treatment. So chemotherapy is a word you've heard very often, and it's scary, isn't it? Okay? HCG. Now this is a little different than your pregnancy bit, okay? HCG is another substance that appears normally in pregnancy and is produced by the placenta. That's the first point. If pregnancy is ruled out, HCG may indicate cancer in the testes, ovary, liver, stomach, pancreas, and lung. Marijuana use can also raise the HCG levels. Alright, again we go to the types of cancers and the organs involved. Take a look at it for some time. Alright. Then you come to inhibin. Total inhibin is a sensitive and specific marker for epithelial ovarian cancers in postmenopausal women. Total inhibin may therefore be combined with CA125 for non-invasive diagnosis of epithelial ovarian cancer, and may also be a useful serum marker to monitor disease-free intervals. So here you have another test which you can use to monitor the progress of the disease, good, bad, or ugly. Then we come to PSA, prostate-specific antigen, also known as callican-3. There's many names, seminin, seminogelectinase, and so on. It's a 34D glycoprotein produced almost exclusively by the prostate gland. It's a serine protease enzyme, the gene for which is located in the 19th chromosome in humans. PSA is present in small quantities in serum of men with healthy prostates, less than 4 if I'm not mistaken, but is often elevated in presence of prostate cancer and in other prostate disorders. While frequently used for prostate cancer screening in older men, not recommended as a screening for younger men. But even the younger men are involved now. In those with prostate cancer, rising levels of PSA over time are associated with both localized and metastatic prostate cancer. Prostate test screening is controversial and may lead to unnecessary, even harmful consequences in some patients. Alright? So this is to be taken in a very, very narrow sense, and your doctor has to determine whether it is really prostate cancer or something else. And you can see the picture down there, that a normal prostate, nothing, no nothing, but an enlarged prostate that may be cancerous. So these are the normal levels. Obesity has been reported to reduce PSA levels. Delayed early detection may partially explain worst outcome in obese men with early prostate cancer. PSA levels, my packet must have come, just take it, you paid, huh? PSA levels can also be increased in prostatitis, that is inflammation of the prostate, irritation, benign prostatic hyperplasia, and recent ejaculation, producing a false positive result. So you have to be careful. Digital rectal examination has been shown in several studies to produce an increase in PSA, which the doctors do. However, the effect is clinically insignificant since DRE causes the most substantial increase in patients with PSA levels already elevated over 4.0. So the normal levels are below, as you can see. It is age related and how it increases in as the years. If the older male, the levels are a little more. Okay. You got S100. Although histochemical staining of S100 protein family has been used for many years in the diagnosis of malignant melanoma, recent studies suggest that one of the proteins comprising of S100 family, as S100B, has particular utility in many aspects of clinical management of malignant melanoma. This protein has been shown to be used in staging malignant melanoma, in increasing prognosis, in evaluating treatment success, and in predicting relapse. S100B is an independent prognostic marker, and pre-treatment circulating S100B concentrations predict duration of survival and in melanoma patients. So a little frightening, isn't it? But you should monitor it. Oh my God, look at the picture and look at the cancer. Survival in significantly lower in melanoma patients with normal SB100 levels compared to those with elevated levels. Circulating 100B levels very sensitive to detect metastatic growth of malignant melanoma, particularly in stage 4 disease where S100 is certainly superior to the laboratory parameters. S100 concentrations reflect tumor mass. Serum S100B levels predict efficiency of treatment. Decreasing 100B concentrations reflect response to therapy, while increasing 100 SB indicates tumor progression. Circulating S100B has a role to play in the decision to switch treatment regimes. And you can see this photo below. It's frightening, isn't it? All right. Then we come to CA 19.9. Its main use is a tumor marker, help to differentiate between cancers of the pancreas and other conditions such as pancreatitis. To monitor a person's response to pancreatic cancer treatment and to cancer progression, to watch for pancreatic cancer recurrence. And guys, you know that CA pancreas is one of the most horrible things we have. If treatment is got in time, fine. Otherwise, the prognosis is not very good. And I know I've lost certain friends and younger friends to this. And it's very, very quick and it's heartbreaking. CA 19.9 can only be used as a tumor marker if the cancer is producing elevated levels of it. CA 19.9 is elevated in about 65% of these bile duct hepatoma cancer. It may be ordered to help evaluate and monitor people with this type of cancer. So I have one case some years back. Rick was, I think, what, 45, 46, and he was a professor, very high repute at the University of Maryland. And suddenly one day he comes up saying he has a stomach ache. He was pointing out to his liver. They did a test and they admitted him. And my friends were there. I wasn't there with him. And he said, I'm going to fight it. And we thought that was the best thing. If you fight, you're going to win. And then one day he suddenly gives up. He says, no, that's it. It's time for me to go. And I think 3 days later, he was dead. I have another young, one of my girls, Jyotsna, her son in Australia is learning to be a physician. He's in the second year of medicine. And he complained, he says, ma'am, mommy, I'm having problems with digestion, pointed out. And Jyotsna herself deals with a lot of cancer in Melbourne. And she immediately got him tested, and there was a problem with his bile duct. So he was put on therapy first and operated. Luckily, they got it out. How old is he? He is about 24. Aryan is. He shares a birthday with my father. And the nice thing, he's down today in Mumbai with his younger sister. I think tomorrow I will go see him, and because Jyotsna is very keen that I talk to him, and he said, I want to talk to Rusby auntie. So I'm going to spend some time with him tomorrow at Vidya's place, because there's a party at Radio Club on Sunday. I don't want to go there because it is her little sister's birthday. Atiti's birthday is there. I would rather talk to Aryan in a room and see what he has in mind, because he's asked his mother that I want to spend some time with auntie. So let us see. He has fought it very beautifully, and he's back into the third year of medicine. He'll be graduating next year. So his grandma was telling me, I met them at the Radio Club a month back, Dr. Vidya Doshi's birthday, and she said, Rose, I'm going for his graduation next year. So I'm happy that Aryan's doing well. I'll be talking to him tomorrow. Okay. So tumor-associated glycoprotein 72, all new names, right? Tag is 72 as we call it. It's a glycoprotein found in the surface of many cancer cells, including ovary, breast, colon, and pancreatic cells. It is a mucin-like molecule with a molar mass of 1000 kilodaltons. TAC72 is a tumor marker and can be measured with radioimmunoassay like CA72-4, in which iridium, that's your radioactive iodine, cytochrome peptide, and iodine 125 CC49 molecule monoclonal antibody. This assay has a good specificity for gastric cancer with a correlation to neoplasia extension. It is used to identify relapses of disease and to follow up treatment. TAC72 is also the target of anti-cancer drugs. These are all fancy names up there in front of you. Yes, this is a two-dimensional view of the glycoprotein. So then you have another one which is quite popular, very careful for women. Human epidermis protein 4, HE4 as it's called, for monitoring recurrence of progressive disease in women with epithelial ovarian cancers. The highlights are human epidermis protein HE4 is secreted protein that is overexpressed and can be elevated in serum of women with ovarian cancer. HE4 increases by 25% or greater in 60% of women with ovarian cancer relapse and progression. HE4 remains constant in 75% of women without disease progression. Keep that in mind, HE4. Some highlights. HE4 belongs to the family of whey acid for disulfide core proteins with suspected trypsin inhibitor properties. However, no biological function of HE4 has yet been identified. HE4 was first identified in the epithelium of distal epidermis and originally predicted to be a protease inhibitor involved in sperm maturation. HE4 is overexpressed in 93% of serous, 100% of endometrial epithelial ovarian cancers, and 50% of clear cell, not mucinous ovarian carcinomas. Although it is non-specific, studies have identified HE4 as one of the most useful biomarkers of ovarian cancer. Oh, take a look at the pictures of the lung. Cytokeratin 19 fragments, CIFRA 21-1, for prognosis and treatment of monitoring patients with non-small cell lung cancers. Now these are highlights now. CYFLA21-1 is the most sensitive serum tumor marker for non-small cell lung cancer. Serum concentrations of CYFLA21 correlate with tumor burden. CYFLA21 is an independent prognostic marker for non-small cell lung cancers. Decreasing concentrations of CYFLA21 after chemotherapy appear to be a reliable marker for treatment and efficacy. Can also be used for esophageal disease and carcinomas. CD40L can also be used for lung cancer therapeutic response. You saw what the lung looks like. Okay, we go further. There are no overlaps here. So you go the primary case and you go the recurrent case. Then you have non-specific enolase, NSE. Non-specific enolase is a substance that has been detected in patients with certain tumors, namely neuroblastoma, small cell lung cancer, medullary thyroid cancer, carcinoid tumors, endocrine tumors of pancreas, and melanoma. Studies of NSE as a tumor marker have concentrated primarily on patients with neuroblastoma and small cell lung cancers. Measurements of NSE levels in patients with those two diseases can provide information about the extent of the disease and the patient's prognosis, as well as the patient's response to treatment. So this could tell you either it's going the right way or the wrong way. Organ to marker relationship, bladder cancer. No tumor marker in urine are recommended for bladder cancer screening. The bladder tumor antigen BTA and the NMP22 tests can be used along with cytoscopy. That's using a thin light tube to look into the bladder. Normal values may allow cytoscopy to be done less often. These tests do not take the place of urine cytology and cytoscopy. For advanced bladder cancer, some of the markers used for other cancers such as CEA, CA125, 99, and TPA may be elevated and can be used to follow patients during and after treatment. And you can see the invasive bladder cancer below. Okay. Breast. No tumor marker has been found to be useful for screening and diagnosis of early stage cancer. At the time of diagnosis, breast cancer tissues should be used for hormone receptors, estrogen and progesterone, as well as for HER2 neoantigen. These markers give information of how likely the cancer is to grow fast or spread, or how likely it is to respond to certain treatments. The marker most often used to follow patients with advanced cancer is to look for return of cancer after treatment of CA115-3 and CEA. The CA27.29 test is also used by some doctors. The CA15-3 and CA27.9 are probably equally sensitive, while CEA is less sensitive. Okay, keep this in mind. We're continuing. These markers are most useful in measuring the result of treatment for patients with advanced disease. In most cases, blood levels go down if the cancer responds to treatment and rise if the cancer progresses. Some doctors use this test to look for signs of recurrence in women who have no symptoms of cancer after their first treatment. But most professional groups do not recommend using these markers to follow women already treated in the early stages of the disease. Colorectal cancers, the marker most often elevated in advanced colorectal cancer is CA and CA19.9. But neither of these is useful for screening tests for colorectal cancer. An elevated CA before surgery may be a sign of poor outcome. If it is high before surgery, the CA may should be normal levels in about 4 to 6 weeks if all the cancer has been removed. Many doctors follow patients after surgery with CA tests every 3 to 6 months or so to look for return of cancer. CA is also used to follow patients who have been treated with advanced or recurrent disease. The CA level will go down if the treatment is working and will rise if the cancer progresses. That's obvious, isn't it? If the CA is not elevated in patients with advanced or recurrent cancer, sometimes CA 99 can be used to follow up on the disease. Treatment. If the treatment with drugs that target EGFR, epithelial growth factor, such as Ceturex, that's Eritibix, or Vestibix is considered, the cancer tissue will first be tested to see if the cells contain KRAS mutations. If the mutation is present, then these drugs are not likely to work and so will not be given. So you come across some new words today, KRAS. Then you've got gestational trophoblastic disease. Trophoblastic tumors include molar pregnancy, a pregnancy that results in a tumor of the placenta, or chorionic carcinoma. Human chorionic gonadotropin, HCG, is elevated in those tumors. HCG testing may be used to find these cancers in women who are who are no longer pregnant but still have an enlarged uterus. HCG measurements during treatment of trophoblastic disease are very useful in looking at response to treatment. After treatment, HCG levels should return to normal. Any further increase could be a sign of cancer has recurred. So again, these are repetitions. Liver cancer. Liver cancers can cause elevated levels of alpha-fetoprotein, AFP. Higher AFP levels occur in most patients with liver cancers. An elevated AFP in someone with a chronic hepatitis or cirrhosis may suggest that they have cancer and lead to testing to see if the liver contains a tumor. Screening the AFP has been useful in parts of Asia where liver cancer is common. Sometimes the cancer is found early enough so that the patient can be cured with surgery. Most hepatitis patients are screened for AFP. A rising AFP level might be a sign of level of cancer. AFP can also be used to help figure out the best treatment for liver cancer and to follow patients with curative surgery or other treatments. Lung. No tumor markers have proven useful as screening test for lung cancer. Some of these tumor markers may be elevated in lung cancers are the carcinoembryonic antigen CA in non-small lung cancer and the neurospecific enolase NSE in small cell cancer. Sometimes doctors will follow these markers to evaluate treatment results. There may be other markers that can be followed, but because lung cancer is fairly easily seen on chest x-rays or other images, tumor markers may be a less important role. Cancer tissues may be tested for defects in epithelial growth factor receptor EGFR to see if the drugs erythropoietin or ereseva may be helpful. Okay.
Yeah, ma'am. Can you want to?
So we come to melanoma of the skin. No tumor marker is of value in finding this disease early. The marker TA90, S100 and some other markers can be used to test tissue samples to help to see if the tumor is a melanoma. Blood levels of TM90 has also been used to help find out if the melanoma has spread. If the blood TA level is high, there's a good chance that the melanoma has spread beyond where it first started. But TA90 can sometimes be high even if the melanoma hasn't metastasized. This is why it is not yet to be used as a plan of treatment or predict the outlook. S100 is also elevated in blood when the disease is widespread. This marker can also be used to see if the melanoma has progressed. You can see something that appears on the skin. Ovarian cancers, I think these are all repeats. Epithelial cancers, most commonly ovarian, is linked with elevated levels of CA125. Other markers that are often measured are CA72 for CA and Lassa P. CA125 is elevated in most women with advanced disease and the standard marker that doctors use. Ovarian cancer, even when advanced, is often confined to the abdomen and pelvis and hard to find through X-ray testing. That is why CA125 is often the easiest and the best way to measure the response of treatment or to find a cancer that has come back. CA125 has been studied as screening tool. At present, most medical groups do not recommend CA125 testing of ovarian cancer screening in women who are not at increased risk because it doesn't seem to find a cancer early enough to help women to live longer. Continued CA125. Another problem with this test is that ovarian cancer is not as common as other types, and the CA125 level may be elevated in other cancers and other conditions. So an elevated CA125 is most likely to be due to some other cancer cause, and may tests including surgery are often needed to rule out the ovarian cancer. It is used by some doctors to screen for ovarian cancer in women at increased risk because of a strong family history of ovarian cancers. These women usually get regular ultrasound or early detection along with CA125 tests. Still, even in women with high risk of ovarian cancer, the testing has not yet been found to find cancers early or help women to live longer. The second most common group of ovarian cancers is the germ cell tumors. Patients with these cancers often have elevated levels of HCG or AFP, which are useful in diagnosis and follow-up. Coming back to pancreatic cancers, I told you, not a very healthy sign. No marker has been found to be helpful in screening for pancreatic cancer. CA19-9 marker is the most useful marker for pancreatic cancer. Most people with pancreatic cancer have elevated levels of CA19-9 in the blood. The higher the level, more likely the disease has spread. CA19-9 level gives information about outlook for patients with pancreatic cancer, but cannot be used to diagnose the disease. CA19-9 levels can be useful in patients' follow-up. Patients whose levels drop to normal after surgery have much better outlook than people whose 19-9 remains high after surgery. This marker has also been used to follow up the effect of treatment for most advanced diseases and to watch for if the cancer has come back after treatment. Some doctors also follow the level of CA in blood, but it may not be as helpful as CA19-9. Come on. Coming back to prostate cancer, the marker most often used to detect prostate cancer is the prostate-specific antigen, PSA. Prostate cancer can often be found in its early stages by measuring levels of PSA. Still, most medical groups recommend that men decide for themselves whether they're getting screened with PSA test is the right for them. PSA is very useful in finding cancer that has come back after treatment. After surgery, the PSA level should be undetectable or near undetectable. Those treated with radiation therapy should also have a huge drop in PSA after treatment, but it can take years before it goes back to normal. A rise in PSA after treatment would mean the disease is coming back for more treatment, should be considered. The PSA can also be used to follow the response of treatment for more advanced diseases. I'll tell you a case history. It's happened to my friend's husband. He tested positive, and a robotic surgery was done where the cancer was, prostate was removed. And he was very regularly, he would have his tests done every few months, PET scans, etc. In the last, about 1 month back, the last test, his PSA showed a slight increase. A slight increase. So his doctor was very careful. He said, let's do a PET scan on you. And they found that his thyroid was affected, it had enlarged. Test was positive, so immediately he was for surgery and the thyroid was removed. And it was positive. He came home, he's doing well, and then another test for thyroid, I think radioactive iodine was done. I don't know what the findings were, but he's doing okay. Only thing is, since his thyroid was removed, his voice hasn't come back to normal. And we laughed that, he's sounding very sexy today, these days. But he's doing well. He goes to work, he's a very, very busy lawyer. And he's very positive about it. He says, I'm going to cook it, eat. It's not going to measure. He must be about 60, 65 at the most. And this is his story of prostate cancer. I had another friend many years back in Pune. He had his PSA was positive, the prostate was removed, and he lived very, very happily for years. And we kept telling him, Baba, go and have your scans done. Go and have your tests done. He says, no, everything's fine, everything's fine. And then suddenly one day, boom, his PSA was very high. And he was feeling down, and we found that that cancer had spread. He didn't live more than a couple of months. So it can happen. I'm not scaring you, but if you have had a positive thing, you must have yourself scanned. I'll tell you the story of somebody who's like my sister in the USA. He was complaining to me, she was complaining to me, says, I'm having a little problem with I'm hurting here. I said, Baba, go and have your breast cancer scans done. And right enough, they found a 2 millimeter cyst in the left breast. So immediately chemotherapy, radio, that started, and the breast was removed. So she's had her kids and all that, so she had the Indian doctor, she says, Arthur, you've already had your children. I suggest we do a complete mastectomy, both the breasts. And she was laughing. He says, my God, really, I'm absolutely flat-chested. And they said, no, don't worry, we will build it. The surgery, luckily she had, she was a very, very thin person. Meena, I don't know if you remember Triki.
Yes, ma'am. I do.
You don't remember how thin she was? So she had put on weight, luckily. So you know what they did? Surgery lasted a little 9 hours. Her sister had come down from Canada. And they took the fat from her stomach and they reconstructed her breasts, both her breasts. And she's in check every 6 months now. And they told her, I said, since you had the kids, she tested negative for the cancer of the ovaries. Since you had the test, you're negative, you have no marker, why don't you have a hysterectomy done on the safe side? And she did 6 months later. She works like a dog. She travels all over America. She comes to India, but she keeps herself in check. And her doctors remind her, hey, it's time to test. In between, she was telling me, my OTPT is high all the time. So my doctor says, have a scan done. So I said, go ahead and have it done. She was very, very scared. This happened about 2 months back. I said, I'm sure you have nothing. And right now, she had her scans done, and it was absolutely normal, thank God. She was very petrified what would come out. And she said, Rosebeh, the moment I had the scans done and everything was normal, the OTPT started coming down. So this can also happen. But she keeps herself in check. She's got 2 girls. Elder one's married. The younger one is back in college doing her degree. Okay, so you have to have that. And Meena, Meena, she's divorced. You know that, no?
Oh, no, I didn't know
A great
that.
boy, yeah, a great boy. My great boy. He's divorced.
Yeah, Ajoy, no?
Yes. He's played quite dirty with her, but she's happy. She's got friends, very good friends. And
Sad.
his
Yeah.
sister.
He did something to you, right? Had
Yes,
something
yes, yes, yes.
years
He did.
ago.
He
Yes,
did.
yes.
He did. He did. He did. He did. Anyway, he's married. Triti's advisor's daughter. Somebody they took around everywhere. I know.
Okay.
I know the girl very well. And anyway, that's their life. But Triti is happy. She's got very, very good friends, excellent friends. And she goes, her daughter's mother-in-law suddenly, my memory lapse. She went the wrong way, etc., etc. They had a scan done, and there was a tumor in the brain. So surgery was done. She's fine. And then she has a very, very dear friend, about 40, 45 years old, who runs the marathon. And Amy told her one day, says, I'm feeling very down, Triti, what do I do? She says, let's go and have you checked up. When they went for the checkup, there was a tumor in the brain, so that was out. So she was petrified. He says, listen, 2 cases in my life in 6 months' time, but both are doing well. Both are doing well. So we're keeping our fingers crossed. And Amy is hardly 40, 45 years old. Becky is about 52, 55. Her daughter's mother-in-law. So known to happen.
Yeah.
All right, then you got cancer of the stomach. Not a very nice thing to have. No marker has been developed for this cancer. Some of the other digestive cancer markers may be elevated, such as CA, CA17-4, CA19-9. If the levels of these markers are elevated at the time of diagnosis, the levels may be followed while the cancer is being treated. For stomach cancers that have spread tumor tissues will be tested for HER2 to see if certain drugs may be helpful as a part of the treatment, and that is a fact. Okay. Then you come to testicular cancers, which the men have. The tumor markers are very important in this cancer and are used by doctors to follow up the cause of disease. Human chorionic gonadotropin (HCG) and alpha fetoprotein are usually elevated in blood of men with testicular cancer. Lactate dehydrogenase is another marker that is sometimes used but is less helpful than the others. There are different kinds of testicular cancers, and they differ in the level and the kind of marker that is elevated. You got seminoma. About 10% of men with seminoma, a type of testicular cancer, will have an elevated HCG. Some of these elevated LDH, but not with elevated AFP. Non-seminoma, more than half men with early stage disease will have elevated HCG or alpha feto or both. Many will also have high levels of LDH. These markers are elevated in most men with advanced disease. The amount of marker found in blood at the time of diagnosis does not often help in predicting outcome, but a very high level of these markers can be a sign of poorer prognosis. HCG is almost always elevated and AFP is never elevated in choriocarcinoma, a subtype of non-semolema. In contrast, AFP but not HCG is elevated in other subtype of known as yolk or sac tumors of endothelial sinus tumors. Many tumors are made up of a mixture of different types of non-seminomas. So seminoma is a germ cell tumor of testes. About 10% of men with seminoma, a type of testicular cancer, will have elevated HCG. Some will have elevated LDH, but none will have elevated AFP. Non-seminoma, more than half the men with early stage disease will have elevated HCG or AFP or both. Many will also have high levels of LDH. These markers are elevated in most men with advanced diseases. The amount of marker found in blood at the time of diagnosis does not often help in predicting outcome, but very high levels of these markers can be a sign of poorer outlook. HCG is almost always elevated with AFP, is never elevated in choriocarcinoma, a subtype of non-seminoma. In contrast, AFP but not HCG is elevated in other types of subtypes known as yolk cell tumor or endodermal sinus tumor. Many tumors are made up of a mixture of different types of non-seminomas. Alright, so these are your, on the E411, which is a very popular Cobas machine even today, all these are present. CA125, 15.3, 99, 72, AFP, CIFRA, CA, NSE, total and free PSA, HE4 and S100. So I suggest, if you want to do a little test, put the name C, blah blah blah, and where the cancer is present. They say this year 3 tests have received the CE mark. This is for Roche. Cobas BRAF mutation for metastatic melanoma. Cobas CRAS test for colorectal cancer. The most recent is the Cobas EGFR mutation test for non-small cell cancer, lung cancers. The system used in Cobas 4800 system versus 2. PCR technology, now the best in the world, helps to detect. Okay. So you've got the melanoma skin, you've got the colorectal, you've got the lung, and these are the test kits, the DNA samples, preparation kit. And there you've got the international symbol, the pink ribbon, and one always earns for a very beautiful nature outside. So this is your whole list of different types of cancer markers, quite a few many. Interesting? Interesting?
Yes, ma'am. Got to learn a lot.
Parizad?
So many things. So many things. Thank you. Thank you.
Gautam bhai?
Yeah, it is actually
बच्चों
tough.
से आवाज नहीं
I believe almost all types of cancers in a nutshell.
Yes.
Even for one laboratory, it is very much useful.
So this is just I've just given a little outline for all of us. In fact, we can't keep going into everything. Of course, if you're working in the lab and we assay it, then it becomes important. But the patient's signs, symptoms are very important. When you do blood tests, we always, like I told you, 90% of patients will tell you what's the matter with them. 10% will tell you, mind your own business. So that's very important. And you see which doctor is referring it. Ne? So if there's a cancer specialist, you know that something is suspected. But the thing is, if you say you're going to fight it, you win. But if you give in, I told you the case of this Triti's guide, advisor. My mother knew him very well. We knew him very well. And he fought, and then suddenly he gave up one day. He says, I don't want to live. Why? I've got this young fellow, 24, 25-year-old Aryan, whom I'm going to meet tomorrow. He says, he told his mother, I am going to fight it. And he has fought it. He's back in college. He's in the 3rd year of medicine.
To best of my knowledge, the patient who is detected this cancer should not hope for their life. They should always keep themselves happy and healthy, thinking very much like that by rising up in the morning after your night sleep. That gives you a very good hope.
True that, you heal yourself. You heal yourself and you say, no, nothing going to happen. I'm going to carry on.
That's it.
All right, guys, anything else?
Thank you.
Thank you. See ya.
Thank you.
Bye-bye.
Thank you, ma'am.
Bye-bye. Bye-bye.
Thank you.
Bye-bye. Bye-bye.
Thank you for the excellent lecture.
Yes.
ma'am.
Acha, like I told Gautam bhai, you came in late.